Hello, am I audible? Doctor I, am I audible? Or Dr. Salva, am I audible? Is my screen
Yes, sir.
visible? Okay, so yeah, we're going to start the infectious disease. I have already recorded the e-focus video. How to use my video now? Like I will be uploading this and the e-focus video also. So how will you use my video while preparing or while revising this infectious disease chapter? Infectious disease chapter is as such is not that vast, but there are some few things which you need to remember. And I have oriented my lecture towards it is exam oriented. That's what I want to tell you. And the main video, which is of e-focus, you need to watch that at least once in order to get the idea of each and every topic which is present over there, right? So this lecture will be only and only exam oriented lecture. This won't take a lot of time, but yeah, once you are done with the e-focus video, then you can watch my video here, and then you will get to know that okay, this is the important thing which I need to remember. So yeah, let's start with the first thing, that is infectious disease, and the first thing is giardia. Very important topic, and And at least one question will be over there in your exam, which will be totally and totally regarding this Giardia lamblia infection. Whenever we talk about giardiasis, we need to remember that it is a protozoa, right? It is a protozoa, which we already know basically. It is a protozoal infection. And what are the clues which they will give you in the examination is they will give a stem in which they will mention that there's a person who went for the hiking. This is the first important clue in the exam that they are talking about the giardia. Whenever you hear about the hiking, you must the first thing which should click in your mind is giardia, the infection of the giardia. Or whenever you hear about the camping, your first click should be towards the giardia. Okay, so hi, any patient who is coming to you with complaints of diarrhea, right, loose motions, and when you are taking the history, and if in the history there's a history of hiking or camping associated diarrhea or the loose motions, that is more towards the giardia. These 2 points are very very important for your exam in order to uh, get this question right for you. So how it happens? Basically, this giardia, which is a protozoa, right? What happens is that the cysts of giardia, more importantly, the cysts of giardia, they are present if someone is infected with the cyst, right? This giardia, which is a protozoa, when ingested, okay, when ingested by a patient, by a person, it goes and remains in the intestine. Okay, it goes and attaches. Okay, as you can see here, see, this is a cyst. Okay, this is a cyst which is ingested by the patient, and once the cyst is ingested, these flagellated tropocytes, they attach with the intestine. They attach with the intestine. Once they attach with the intestine, what they will do is that they will result in pain and malabsorption. They will result in pain and malabsorption. So Just think about this thing. If there is a patient who is infected with these cysts, okay, the cysts of giardia, eventually it has these flagellated tropocytes, as you can see here, and these flagellae are there in this protozoa for the attachment, and they attach with the intestine, right? They attach with the intestine. More importantly, once they attach with the intestine, they result in the malabsorption of fat soluble vitamins. Okay, fat soluble vitamins. Now tell me, what are the fat soluble vitamins? The fat soluble vitamins are vitamin K, vitamin E, vitamin D, and vitamin A, right? These are the fat soluble vitamins. So anything. So it basically results in the fat malabsorption. Fat malabsorption. Very important. Okay. So just imagine if there is a patient who is having fat malabsorption, and now once he is having loose motions, what will be the appearance of that stools, that loose motion? See, as you can see here, it will be fatty stools, right? It results in pain. It results when it's attached with the intestine. It results in pain. It results in malabsorption because there is malabsorption of fat soluble vitamins and basically the fat, right? This fat now comes with the stool, resulting in fatty stools. Number one, because
Can't
it is
see
having. Sorry,
your screen.
you cannot see my screen.
No, sir.
Can you see it now?
Yes, sir.
Okay. So, where was I? So yeah, I was talking about these fatty stools, right? Fatty stools, which is basically due to the malabsorption of the fat. That's the first thing. Second point is that the diarrhea which is caused by this GRDSS is non-bloody. Can you see it here? It is non-bloody. Every patient, any patient who has a history of hiking or camping and comes to us with non-bloody diarrhea, the first thing which should click in our mind is this GRDSS. Okay, GRDSS. And if you see that the patient will have flatulence, foul smelling, fatty stools, and diarrhea. And another clue in the exam will be explosive watery diarrhea. Explosive watery diarrhea. Sometimes they will write over there that the diarrhea is bubbly in nature. Okay, it's bubbly in nature, explosive watery diarrhea, foul smelling, and flatulence. Of course, the patient will have abdominal pain. So this is what you need to remember. And what is the incubation period? 1 to 2 weeks. So you need to ask the patient, is there any history of hiking or camping 1 week before? And of course, the answer will be yes. Of course, the answer will be yes. Right. This is the first thing which you need to remember about the GRDSS. There are only few clues which will be there in the exam, and one of them is explosive watery diarrhea, hiking, camping, okay, and non-bloody watery diarrhea. Important. Now, let me give you one important table which I want you to write. Okay, write it on a separate copy or on a sticky note and just paste it in front of your table. And the table is, and that flow chart is, any patient who is having
Sir,
traveler.
screen.
Oh my god. What's happening? See, yes, we need to reboot the device if we cannot restart the podcast. Actually, what happened is that my iCloud is, filled with these videos and all. That's the reason it's getting terminated each and every time. So yeah, now you can see my screen, right?
Yes, sir.
Now see, any patient who is having traveler's diarrhea, right? Any patient who is having history of traveler's diarrhea. What is traveler's diarrhea? How can you define it? It is defined as three or more, three or more loose watery stools. Okay, three or more loose watery stools in 24 hours. Okay, in 24 hours, very important, as three or more loose watery stools. If there is any patient who is having only two loose watery stools, that means it's not a case of traveler's diarrhea. Plus, there should be one or more what? Either the patient is having abdominal pain, okay, fever, nausea, or vomiting, or the patient is having bloody diarrhea, bloody stools. Okay, this is the definition of traveler's diarrhea. Now, there's a beautiful flowchart which I want you to remember, and that is this one. See, once there is a traveler's diarrhea history, okay, now the first thing you will ask the patient, tell me about the appearance of this diarrhea or the loose motion. Is it bloody or watery? So we have classified the traveler's diarrhea into bloody diarrhea and the watery diarrhea, right? You can use this thing in your during your internship also. If there is a patient who is having diarrhea episodes, okay. Now, if it's bloody, just remember only one point, that's incubation period. Okay, incubation period. That's very important. And for this, again, incubation period. When we talk about the bloody diarrhea and we talk about the incubation period, if this bloody diarrhea has started within 12 to 48 hours after the travel, remember that it could be either salmonella or it could be E. coli. Okay, this incubation period is very important. This will help you to solve each and every question of traveler's diarrhea. Number second, if the history is after like 48 hours, this bloody diarrhea started after 48 to 72 hours of travel, then it could be either Shigella, okay, or it could be Campylobacter. Now the third one, if it is after 7 days, okay, that's mean 1 week. After 1 week, it could be ant amoeba histolytica. Okay, and amoeba histolytica. So as you can see from this very flow chart, you will get to know about some questions. Number one is the incubation period. Number second is what are the organisms, what are the microorganisms which result in bloody diarrhea. It is salmonella, E. coli, shigella, campylobacter, and entamoeba. And base it on, if the history is saying that the patient has a bloody diarrhea, now after that you just need to look at the incubation period. If he is complaining of bloody diarrhea after 48 hours of travel, then it could be shigella or campylobacter. If he is complaining of bloody diarrhea after 7 days, then it is entamoeba histolytica. Then when we talk about the watery diarrhea, okay, watery diarrhea, if it is within 1 to 6 hours, it is either staph aureus, okay, or it is Bacillus cereus. Okay. Then if it is after 2 to 5 days, it is cholera. And if it is after 7 day, then it is none other than your GRDA. Can we see it here? As I already mentioned, if we go back and see here, the incubation period is after 1 to 2 weeks. So, any patient who is having watery diarrhea, as we have already mentioned over here, non bloody. So, again, we will go back to our flow chart. Any patient who is having watery diarrhea, right? And this watery diarrhea episode is after 7 days of travel, that is GRDSS. That is GRDSS, right? Clear? So this is how you will approach any question which is related with the diary. The first thing should be, is it bloody or watery? Then you will accordingly follow the flow chart. Now, the other important point is, what is the treatment? This is the most important thing which you need to remember in any patient of GRDSS. What is the treatment? So the treatment is very simple. It is your you need to go for tablet, that is metronidazole. Okay, metronidazole. And you know that this metronidazole is used for the symptomatic. If he's symptomatic, that means he's having this explosive watery diarrhea and all. Now the treatment you will use is metronidazole. Any patient who is having such kind of features, you will go for the metronidazole. This is your question. Okay, this is your important question. Now, second thing, if he's asymptomatic, if he's asymptomatic, what you will do? You will do nothing. You don't need to do anything if the patient is asymptomatic. If the patient is asymptomatic, and for example, you went for the stool serology and all, and you found out that the patient is having the stool is having the presence of uh, Giardia cystis and all, or the tropocyte, then yeah, you will, but the patient is asymptomatic. You don't have to do anything. Sometimes we go, for example, there's a patient who is having epigastric pain, or we are suspecting that the patient is having uh, ulcerative colitis, or the patient is having any duodenal ulcer due to the H. pylori. We always go for the stool examination, right? And once we go for the stool examination, if we found out that the patient is having um, Giardia, cystis, and all, but the patient is asymptomatic regarding this, or the patient does not have any sign symptom which is related with the GRDSS, then you will not treat him. Okay, that means asymptomatic patient, we don't do anything. That's it. Now, if it's a patient of GRDSS and the patient is pregnant, what you will do is that you will again use either metronidazole, or you can use paramomycin. This paramomycin is actually important for those patients who are sometimes, like, the patient is pregnant, right, and she's asymptomatic, but on the stool examination the patient is having giardia, right? On the stool microscopy you found out that the patient is having those three specimen of you went for the three specimen of feces for the analysis, and you found out that the patient is having giardia tropocyte. At the time you can go for the paramomycin, right? But most importantly, this is only and only used if the patient is pregnant, and she is having symptomatic GRDSs. Either you can go for metronidazole or paramomycin. So sometimes they don't give you the option of metronidazole. At the time you can go for the paramomycin. What are the alternative drugs? You can use albendazole, mebendazole, okay, or nitazoxamide. But yeah, the important points are metronidazole. What is the treatment for GRDSS? Metronidazole, which comes in the form of metrogel, right? What is the incubation period? 1 to 2. What is the characteristic features? The patient will have explosive diarrhea in the history of hiking or the camping, right? Incubation period of 1 to 2 weeks. More importantly, after 1 week, it will be non-bloody, uh, fatty stools, malabsorption, bubbly appearance. That's it. Now, let's see this one. It is your what? It is your ant amoeba histolytica. Okay, it is ant amoeba histolytica. If we go for the ant, if we talk about the ant amoeba histolytica, before that, I just want you to remember one point. Those who come from New Guinea, okay, and complain of non-bloody watery diarrhea, just think about GRDSs. Papua New Guinea is filled with two things: malaria, number one, and the number second is GRDSs. Okay, think about only these two things. Malaria, the patient's having like high grade fever, patient is having uh, like flu like symptoms. Okay, the fever is the patient is having hepatosplenomegaly, the patient is having confusion and all, which we called as black malaria. Think about this. Think about the malaria in case the patient has a travel history for Papua New Guinea. That's it. Now, when we talk about the ant amoeba histolytica, the first thing which you need to remember is, if you can see here, okay, if we can see here, this ant amoeba histolytica, it results in amoebiasis, right? It results in amoebiasis. Okay, it results in amoebiasis. And of course, this ant amoeba is a protozoa. Again, it is a protozoa, and most most patients are asymptomatic. Most patients are asymptomatic, and it can be seen mostly in India and South America, Central and South America. That's not important. But what is important is that this ant amoeba histolytica, it's not very common in travelers. But if we'll go back to our table and we see here that any patient who is having bloody diarrhea and the incubation period is more than 7 days, that means it has this bloody diarrhea has the episodes of bloody diarrhea has came after 7 days of travel. That is more importantly your anti-amoeba histolytica. So see, this table is very important. That's the reason this the flow chart which I started first, which I mentioned first, is very important for your exam, because this will help you in each and every question, right? But most important thing is that most patients are asymptomatic, right? And the important point, another important point is that once once there are these mature cysts, you ingest that. Okay, your ingestion of mature cysts or tropocytes of this ant amoeba histolytica, once ingested, these matured cysts, there is excistation and results in the formation of tropocyte. Okay, this encystation of cyst happens in the small intestine. Okay, you ingested the mature cyst, okay, due to the fecal-oral route. Okay, this is importantly, this is present in like any water bodies and all. Okay, now what will happen is that this will reach and this will remain in the small intestine. Once this matures cyst, it ruptures and results in the and results in excistation and results in the formation of tropocyte. There is then the multiplication of these tropocytes in the large intestine. Once there is that, then it can move to any other place. It can move to any other place. Now, where it can go, I have just created a very beautiful diagram over here. So once it's in the intestine, from the intestine it can go towards the liver, right? This is the first place, right? From the intestine, the what are the extra intestinal manifestations of entamoeba histolytica? It can, of course, involve the intestine, resulting in what? Resulting in bloody diarrhea, Why is there bloody diarrhea? Reason being is it results in the formation of ulcer, and this ulcer is flask-shaped ulcer. Okay, flask-shaped ulcer, just like this. If we'll if we'll go on the Google and type ant amoeba histolytica flask-shaped ulcer, this is the only diagram which you will see. Just like this, the intestine will, of course, will have this kind of picture over there, this kind of ulcer. Now, once there's ulceration, of course, the patient will have bloody diarrhea, and it will be after 7 days, right? From the intestine, it can move and go to the liver, right? Once it goes to the liver, it results in the infection of the liver. Even it can result in the abscess, abscess formation or the cyst formation over there. More importantly, the abscess. Once there is formation of abscess, of course there will be release of interleukins and all, and the local inflammation will happen, resulting in right upper quadrant pain and tender hepatomegaly. Remember that one thing is missing over here. The patient will have tender hepatomegaly. That is important. Okay, that's very, very important. The another important point is that from the liver, it will go towards the lung through the, you know, if it will go back towards the anatomy of the liver, there is that covering of the liver, right? The liver capsule has a bare area, BARE, which is not covered by the serosa and all, the protection layer. From there, this and amoeba histolytica, these tropocytes, right? What can happen is that they will escape, they will trespass and will move towards the lung. And that means the lung can also have the abscess. From the lungs, it can go to the heart. From there, it can go to the brain. So these are the locations where this abscess can be found. This extra intestinal manifestations of anti-amoeba histolytica can be present in liver. That is the most common extra intestinal manifestation, resulting in the formation of abscess, followed by lungs, followed by heart, followed by brain. That's it. From the liver, it can through the portal vein, right? Through the portal vein, we know the portal vein is found by the superior or inferior mesenteric vein and plus the splenic vein, right? Now, from the splenic vein, it can from the splenic artery, sorry, it can go towards the spleen, resulting in splenic abscess. From the spleen, it can go towards the kidney, resulting in perinephric abscess. So these are the extraintestinal manifestations. But important point is the spleen will just have the abscess and not the its size will not increase. So splenomegaly will be absent. Splenomegaly will be absent. Okay, and what is the important point here? The important point is any patient who is having bloody diarrhea and it has started after 7 days of travel, right? And now the patient is complaining of a right upper quadrant pain. A right upper quadrant pain, think about what? Liver abscess, which is caused by the entamoeba histolytica. If there is cough, okay, if there is product to cough or respiratory symptoms, after right upper quadrant pain, think about the patient is having lung abscess. Okay, and yeah, so if we'll see this, the form of abscess which is formed by this and amoeba histolytica in the liver, it is just like what we call as anchovy paste. Okay, anchovy paste. This is from the BMJs. Okay, and this will just look like this anchovy paste. And how do you diagnose that the patient is having this amoebic liver abscess? The first important point is, of course, the patient will have right upper quadrant pain. The patient will have hepatomegaly. Okay, and this hepatomegaly will be tender, right? Tender. Patient will have very high fever. That's also important. And these are the clinical features. Of course, these are just the clinical features and not diagnosis. Now, when we talk about the diagnosis, how do you diagnose such patients? You can go for the serology. Okay, I'm talking about the amoebic liver abscess. You can go for the serology for amoeba and imaging. And you can go for imaging. And this imaging is done by CT scan, and nothing else. You won't go for the ultrasonography, but CT scan. Now, again, what will be the symptoms? The patient will have bloody diarrhea. Patient will have flask-shaped ulcer. These are the intestinal clinical features. The patient can have now liver abscess. This will look like an NCOV page. The patient will have right upper quadrant pain. If we go back here, all of it generally is acute dysentery or bloody diarrhea, fulminant colitis, that's the inflammation of the colon, amoebic appendicitis of the colon. Okay, it can result in the inflammation of appendix also. But don't confuse it with the pseudoappendicitis that is seen with something else. So yeah, don't confuse it with uh, pseudoappendicitis. It is just the proper or the frank appendicitis or the real appendicitis due to the inflammation of the appendix, or result in the formation of fecolith obstruction of this appendix, resulting in the appendicitis. Here you have to score what? What is the type? What is the score which we use for the appendicitis? Mental score, right? If you don't know this, just search it on Google. Then I will ask you what is mental score. It was previously known as Alvado score. Now it's called as mental score. Okay. Now invasive extraintestinal amoebiasis. I have already mentioned about this. So there's nothing new about this now. Okay. So yeah, this is done. So okay. Now let's talk about the management part now, because management part is very important. If there is asymptomatic patient, if there is asymptomatic patient of entamoeba histolytica, okay, as gut is involved, okay, and that can trans that can pass in stool and even invade can even invade the colon. I'm talking about what? Entamoeba histolytica. It can, because it has the capacity to result in ulceration. So therefore, if the patient of entamoeba histolytica is asymptomatic, we still have to treat the patient because it can invade the lumen of that means colon. It can invade the colon, right? So it can even invade the colon. Therefore, what do we need? We need luminal agents, right? We need luminal agents. That's important. And what is the luminal agent which we have, which I previously talked about? Paramomycin. So if they give a question, if they give a question that the patient is asymptomatic, they will give a long stem where they will mention that the patient is having on like for we went for the investigations, or we went for the diagnosis or the investigations for entamoeba histolytica. We went for the stool microscopy where we found out that the cystis or the tropocytes of entamoeba histolytica has ingested the erythrocyte, that means the RBCs, right? And or we went for the antigen testing, or we went for the PCR, and it is a confirmed case of entamoeba histolytica, but the patient is asymptomatic. Which of the following should be used for the treatment of such patients? We can go for paramomycin. Okay, very important. Now, tell me one thing. The second point is, second MCQ is, if the patient is now symptomatic, just like the bloody diarrhea and all, symptomatic amoebic dysentery. What is the first line? We can use tinidazole. Okay, we can use tinidazole, or we can use metronidazole. So either we can use metronidazole, okay, or we can use tinidazole. That's it. Now, plus we can add paramomycin. Why? In order to in order to decrease the relapse of entamoeba histolytica. Now, let's talk about the severe case of entamoeba histolytica. As we said that it can result in a formation of ulcer, flask-shaped ulcer. That flask-shaped ulcer can perforate, right? That there would be perforation. Once there is perforation, there is peritonitis, right? So if the patient is having perforation or the patient is having peritonitis or the patient is having frequent bloody stools, or it can sometimes result in toxic megacolon. The treatment for such patients is again tinidazole or metronidazole. Why? What was the why did I mention this very thing? Because sometimes they will give this question and will mention that the patient's having perforation and all due to the and the causes and amoeba histolytica. What you will do next? Of course, you have to go for the ABCD criteria. If that's okay, then this next thing you should do is tinidazole or the metronidazole. Okay. Now, if the patient is having this liver abscess, what is the treatment? Again, tinidazole. More importantly, it will be the first thing will be metronidazole or tinidazole. Then you will of course go for the diagnosis of amoebic liver abscess. You will go for the serology or CT scan. Of course, you need to add here paramomycin. So in each and every case, you have to add the paramomycin, right? In such patients, you have to add the paramomycin. Why don't we use the met in case of perforation, peritonitis, and frequent bloody stools? Why don't we went for the paramomycin? Because it's already perforated. We were using this paramomycin because it's a luminal agent. It's killing this uh, ant amoeba in the intestine. Once there is already perforation, there is no usage of that. Okay, this is what they say. Okay, now let's talk about the schistosomiasis. Schistosomiasis. If we talk about the schistosomiasis, whenever they give you a question and they mention in the stem, there is this word written over there, that's snail. Okay, if we just hear about the snail, okay, whatever the symptom will be there in the patient, and the option, one of the option is schistosomiasis, go for it without reading every point then. Okay, you don't need to read all the points after that. If there is snail written in the question, you have to go think about the schistosomiasis. This is not something fancy, or I'm not telling something which has not come in the exam. They have given this very question in the exam. Even I got this very question. I just looked at the snail in the stem, then I just directly went for the schistosomiasis. Okay, so this snail, once you hear this word in, or you just read this word in the exam, you directly go for what? You directly go for schistosomiasis. Now, what happens is that this snail, okay, whenever I talk about now this snail has these schistosomiasis inside. Okay, these snails have these schistosomiasis inside, and this schistosomiasis releases this cercaria. Okay, they are released by the snails actually, because this snail contains these schistosomiasis. The schistosomiasis, just like these eggs, okay, they release their eggs in the form of cercaria. If I need to make it very simple, this is how I make. They release these eggs in the form of cercaria. These cercaria are the ones which infect the human humans, which infect the humans. Now they penetrate the skin. The point where they penetrate, okay, the point where they penetrate, they result in local reaction at the point of penetration, or the at the point of penetration, they result in this local reaction. This is what we called as swimmer's itch. This is what we called as swimmer's itch. This local skin reaction, okay, at the site of entrance or the penetration is what we called as swimmer's itch. Right. Now, from the point of entrance, what it can do is that it can move, okay, and it can infect the bladder, right? It can involve the bladder, it can involve the vulva, okay? It can go and infect the intestine, okay? It can go and infect the intestine or the bowel. It can go towards the liver also, right? So therefore, the intestine basically has mesenteric plexus. It remains over there. In the bladder, we have vesical plexus. Vesical plexus. It remains over there. This cystosomiasis, it will be present over there. And now, just think about this. If the patient is having this involved due to the cystosomiasis in the intestine, or it's present in the mesenteric veins, these eggs then can go towards the liver. That's what you already know. Now, what are the things which it can lead, or which it can manifest in the intestine? Of course, the patient will have abdominal pain, because it is in way because it is associated, or it is present in the mesenteric veins, mesenteric plexus, or the intestine, right? Patient will have abdominal pain, patient will have fever, patient will have myalgia, and patient will have urticaria, right? The patient will have urticaria. And this is any patient who, like, for example, there's a patient, and he he went into a pond or a river, and he was swimming over there, and now the patient is having a local skin reaction. Now he is having itching or urticaria there. Eventually, now the patient is complaining of abdominal pain, fever, myalgia. Think about what? Cystosomiasis. And this is what we called as Katayama fever or Katayama syndrome. Okay, Katayama syndrome. The most important point, which I have already mentioned, is snail cystosomiasis. SS. Okay, S snail. That's it. Even sometimes, what happens is that once it goes towards the liver, it can result in what? Because it infects the liver, it results in hepatomegaly. Okay, it results in hepatomegaly. It can even result in the fibrosis of liver, resulting in fibrosis. Okay, it can, once there is fibrosis, think about the patient. If this is the liver, okay, and this is the portal vein, and This is your spleen. Okay, this is splenic vein, right? This is splenic vein. This is inferior mesenteric vein. This is portal vein. And now there is fibrosis over here. What will happen? There is fibrosis. The hydrostatic pressure in the portal vein will increase, right? This will result in portal hypertension. This happens in each and every patient of liver fibrosis. Once there is portal hypertension, it will have a backflow and result in the enlargement of spleen, also resulting in splenomegaly. So such patients who are having schistosomiasis, it can result in splenomegaly and hepatomegaly also. But when we talked about a patient who has a bloody diarrhea, we just talked about hepatomegaly, okay? Because entamoeba histolytica just results in the tender hepatomegaly and not the splenomegaly, right? That is the difference between the schistosomiasis and the entamoeba histolytica. Of course, the schistosomiasis will not have the this what we say that in the schistosomiasis the patient will have some other manifestations also, like the terminal hematuria also, but that's not always present over there in the question. Sometimes they will not mention about the terminal hematuria. They will just mention about the bloody diarrhea, dark red bloody diarrhea. Now the patient is having a right upper quadrant hip, like this hepatomegaly. Again, the patient is having splenomegaly also. At that time, you have to rule out what you will think about. Okay, this cannot be a case of entamoeba histolytica, because we know that entamoeba histolytica, of course, the patient is having bloody diarrhea, but the patient will not have splenomegaly, right? Splenomegaly is there with schistosomiasis. Done. So from the vesical plexus and due to the involvement of the bladder, it will result in terminal hematuria. Even it can result in bladder carcinoma. Now, the important point over here is now the first two, there are basically, if we talk about the schistosomiasis, there are three types of schistosomiasis. It is schistosomia mansoni, okay, japonicum, and hematobium. These two, M and J, they are present whenever they go. They love to be there in the mesenteric plexus. So they will have intestinal manifestation. But this hematobium, this hemato means blood. So it will have present in vesical plexus and result in terminal hematuria and the bladder carcinoma, right? So that's it. Sometimes they say that the schistosomiasis, it can result in neurological sign symptoms, okay? Right, for example, focal CNS signs, increased ICP. Even sometimes they say that it can result in transverse myelitis or cerebellar or the cerebral neurocystosomiasis, or any patient who is having cystosomiasis with seizures, right? Neurosign symptoms. Then you have to think about the neuro cystosomiasis. It can, from the liver, it can go to the lungs, right? It can go towards the lungs, and in the lungs what it does is that it results in the granulomatous formation. So results in the granuloma formation in pulmonary artery. So sometimes they will ask you that these granuloma formation due to the cystosomiasis is present in the artery or alveoli. At that time you have to know that this artery will have the granuloma formation and not the alveoli. Okay. Okay, now the patient will have, of course, the granulomatous pulmonary and arteritis. Patient will have pulmonary hypertension also, and that's it. Now, what about the diagnosis? Okay, any patient who is from Egypt, think about schistosomiasis and Swimmer's itch. Swimmer's itches, which I have already mentioned, the second reaction at the parasite penetration. That is what we called as Swimmer's itch. How do you diagnose such patients? You will go for the serology. Okay, this is having high sensitivity and specificity. Then you can go for the Schistosoma mansoni and japonicum. Think about what we'll do, because they remain in the intestine. They will pass their eggs in the stool. Okay, and if we go for liver ultrasonography, the patient will have fibrosis, right? And we can think about the rectal biopsy also. Then, when we talk about the cystosoma hematobium, because it is present in the bladder, therefore we go for the bladder biopsy. We can have eggs in urine or kidney, and we can go for bladder ultrasonography, right? Bladder ultrasonography. Then, what is the treatment of cystosomiasis? When we talk about the cystosomiasis treatment, we always talk about praziquantel. Okay, plus you can add the glucocorticoids if the patient is having neurological sign symptoms. Tell me, what is the treatment for GRDSS? Dr. Salva, is my screen visible?
Yes, sir.
What is the treatment for yeah, sorry. What is the treatment for
Metronidazole.
GRDSS?
Metronidazole.
Okay, just tell me one thing. If the patient is having bloody diarrhea and the symptoms are after 7 days of travel, and the patient is asymptomatic, and the patient is having severe symptoms of right upper quadrant pain, and you thought about that, you suspected that the patient is having amoebic liver abscess, what is the treatment for them? Amoebic liver
Uh,
abscess.
Tinidazole, metronidazole plus paromycin.
Yes, paramomycin and the metronidazole, which you have to start in the patient. If the patient is having terminal hematuria, and the patient has a history that he was swimming in a pond or a river where snails are present, you suspected that the patient is having cystosomiasis. Now he's presenting with terminal hematuria. What is the most appropriate next step? It is you can go for the urine collection for the cystosomiasis hematobium X, or you can go for the bladder biopsy also, right? You can think about the biopsy, or you can even take the biopsy from the kidney, but that's not done, of course. We can go for the X in the urine, we can go for the bladder biopsy. If there are symptoms of if there are intestinal symptoms, then you have to think about what cystosomiasis mansoni and the japonicum, and the patient needs treatment with the praziquantel and the glucocorticoids if the patient is having neurological sign symptoms. Snail is very important over here. What is this? This patient has, he was in Egypt, and now he's having this patient is having this bloody diarrhea. Remember that the patient of cystosomiasis will also have bloody diarrhea. It is not due to ulceration and all. It is basically due to the malabsorption of iron. you know, iron. The iron is, it is absorbed in jejunum, right? And schistosomiasis, because it involves the mesenteric plexus, it does not, allow the iron for the absorption. And once the iron comes in the stool, if we have seen that the iron, once it's exposed towards the air, it becomes dark. So the patient will have dark red bloody diarrhea. It will just look like a bloody diarrhea, but it is basically the iron which is malabsorbed and comes in the stool. It seems to be the patient is having dark red bloody diarrhea. And see, such patients who have this history of travel to the Egypt and now come with such symptoms. This is ascites, and such patients have, of course, maybe this patient has liver fibrosis. So you have to go for what? You will go for the diagnostic test for eggs in stool for schistosomiasis. You can go for the ultrasonography of liver. Of course, this patient is having portal hypertension, and this portal hypertension due to the increase in hydrostatic pressure. Now the patient is having ascites. This fluid is leaking and is collecting in the peritoneal cavity. You have to go for the paracentesis in such patients. So that's all for schistosomiasis. Now, can you see it here? What are these? These are cystis, right? Tell me, like, which is the most, very, I would say it's a very famous disease, which we always and always study in surgery. This is basically hydatid cyst. Hydatid cyst. And this hydatid cyst, it is caused by Echinococcus granulosus. Granulo, okay, Echinococcus granulosus, right? And the important point about this Echinococcus granulosus is that basically they are except we say that they are the parasite of dogs. Okay, these dogs are very prone to have Echinococcus granulosus. Echinococcus granulosus is present. The its eggs are present in dogs, and when the dog does feces or passes the stool, right? For example, this is a stool of a dog. Now, what happens is that this is taken by the sheep, okay? And of course, the sheep is eaten by us, okay? That is humans. And now this human is having what inside? Echinococcus granulosus. Echinococcus granulosus. Now this human is having Echinococcus granulosus. Before that, I forgot about one thing, that is how do you diagnose a case of Entamoeba histolytica? You diagnose it with the stool microscopy, because it's of course present in the intestine. It invades the, it is attached with the intestinal epithelium. It can invade it. It can result in the formation of ulcer. Now, because this is present in the intestine, the stools can pass, its tropocyte can pass in the stool. And once you go for the stool microscopy, for example, this is the microscope. Okay, I don't know how did I, okay. What you will see is that you will see this tropocyte, okay, you will see this tropocyte of ant amoeba histolytica, And inside the tropocyte, you will see these red cells. These are basically your RBCs. So, and amoeba histolytica results in the ingestion of RBCs. Erythrocytes, which are present in the tropocyte of Entamoeba histolytica, is classical for amoebiasis, that is the Entamoeba histolytica. You can go for antigen testing also. Okay, you can go for the PCR also. You know what is the advantage of antigen testing and PCR? The advantage is that it can distinguish between Entamoeba histolytica versus Entamoeba dispar. Both come in the family of Entamoeba, so it will help you to uh, distinguish between whether it's a case of whether it is a Entamoeba histolytica or Entamoeba dispar. Serology is not very famous for the Entamoeba histolytica. Most important in and endemic settings, it's not done. You can go for the sigmoidoscopy also or colonoscopy and take the biopsy if you are not able to diagnose a case of Entamoeba histolytica, but this won't come in your exam. Now, going back, so we are talking about this Echinococcus granulosus. So now, can you see it here? The main manifestation of this Echinococcus granulosus is nothing but it results in the once this Echinococcus granulosus is present in the dog, its eggs are present in the dog intestine. The dog passes his stool that's taken by sheep. Sheep is eaten by the humans, and the human gets Echinococcus granulosus. Now, this parasite, okay, this Echinococcus granulosus, it can migrate anywhere. Okay, it can migrate anywhere from the intestine, but it goes only towards two important locations. One is liver, and the other one is lung. In the liver, it results in the formation of cystus, that is your hydrated cyst, and this is hydrated cyst over here. This is hydrated cyst over here. Can you see it here? Can you see this ring of calcification which is surrounding this? Okay, this is classical for hydrated cyst. Hydrated cyst. Can you again see this very bright ring? Can you see it here? This is what we called as hydrated cyst, because sometimes you have to sometimes you have to distinguish it from the amoebic liver abscess. The abscess will not have this bright ring or this septate formations. Okay, this is classical for only cyst. Now this lung can also have the cyst formation. Hydrated cyst, hydrated cyst present in the lungs. Will the patient of this um, um, hydrated cyst or this Echinococcus granulosus will have the splenomegaly? The answer is no. The patient of hydrated disease won't have splenomegaly, but of course, because it is infecting the liver, it results in what? Hepatomegaly. It results in hepatomegaly. It results in hepatomegaly. Mostly the patients of hydrated cyst are asymptomatic, so we find it incidentally on when we go for ultrasonography for any other disease. We see such patients who are working in who are farmers or working in a farm, sheep farm, okay, or have or they are having dogs over there. and the patient is having any other disease, and you went for the ultrasonography and you found out that the patient is having cyst in the liver, so it is mostly a case of echinococcus granulosa, that is hydatid cyst. And therefore, the most important point is that most of the patients are asymptomatic. If it results in the involvement of lung and cyst formation, it will come up as a case of hemoptysis. The patient can have chest pain, even dyspnea can be there, cough and dyspnea. Okay, and remember that if we don't treat these asymptomatic patients, even what will happen is that it can rupture. It can rupture and results in the anaphylaxis, and the patient can die. Therefore, even if the patient is asymptomatic, we have to treat such patients. Can you see these septate formations? Right? It is a case of hydatid cyst. Okay, there will be septations, right? There will be septations. Now, uh, how do you diagnose such patients? How do you diagnose? Remember that if we go for the CBC, see the only one disease in whole infectious medicine for AMC where even the CBC is important, that is hydatid cyst, because the patient will have eosinophilia. Okay, please see any patient, if they will give a case of any infectious case where you suspect that the patient is having hydrated cyst, that means the patient may complain of right upper quadrant pain, patient is having hepatomegaly, patient is having vomiting, nausea, fever, and the and in the CBC they have given the CBC and the patient is having eosinophilia, that is a clear cut case of hydrated disease. And think about the echinococcus granulosus, right? So there will be mild eosinophilia and LFTs will be abnormal. So it will be LFTs will be raised. It will be deranged. ALTST will be deranged. You can go for serology and antigen assay, where you can think about the ELISA. Okay, and this ELISA, it can be used for primary diagnosis and follow up and treatment. So if they talk about the most important test for the diagnosis of entamoeba histolytica, that is ELISA. The CBC is always given in the stem. They will just give you the stem where they will mention about the eosinophilia. Think about the entamoeba histolytica. If then they will ask you how do you diagnose, you can go for the uh, not the entamoeba histolytica. Think about the disease. Then you have to go for the ELISA. Once you go for the ELISA, it can be used for the primary diagnosis. It can be used for the follow up after treatment. A negative serological test does not rule out echinococcus granulosus. And the cyst aspiration and biopsy. If serologic test which you have already done and it is negative, if it is negative, what you will do is that you can even go for cyst aspiration. But this is never your answer in your exam because they don't give you such typical or such typical symptom in the examination, that the patient has went for the ELISA and that's negative. Now what you will do next, even if they will give you, you can now answer, you can go for the cyst aspiration, but you always have to remember that there is the risk of anaphylaxis if you went for the aspiration. So we have to be very cautious about this. If they talk about the imaging, of course, you can go for the ultrasonography, right? It is the best initial radiological test. Best initial radiological test where you will see egg shell calcification, which we have already seen. And second test, which is confirmatory, uh, is your CT scan or MRI. But the best initial is ultrasonography. Now let's talk about the treatment. How do you treat such patients? How do you treat such patients? Remember that such patients who are having echinococcus granulosis, and the patient is having, of course, the primary manifestation will be of cyst. You will see singles if it is single cyst, okay, and the size is less than 5 centimeter. You will just give albendazole. You will just give albendazole, right? Then, if the cyst is 5 to 10 centimeter, the first thing you will do is give albendazole, which is followed by peer. That is puncture aspiration, injection, and reaspiration. As I said that, I don't know why eMedicine have still given you a question where the answer is peer. Okay, but in the ETG, that is therapeutic guidelines, they mention that we don't do this nowadays. But still, maybe that's not exam oriented. I think you should follow the e-medicine because that's something which is even used by the local graduates over here. So yeah, you can go for the peer. So cyst 5 to 10 centimeters, go for the albendazole followed by peer, right? Then mm, after 10 centimeter, if the cyst is more than 10 centimeter and there are multiple cysts, you can go for resection. You can go for resection. You can go for resection, and that's it. That's it. Please remember one point. If this echinococcus resulted in blary obstruction, right? Then endoscopic stent or in the blary tree with or without sphincteroplasty can be done. I don't think that they will ask you this question, but still, just let me write this statement. If it results in blary obstruction, you can go for the blary stent with or without sphincteroplasty. That's it. I mentioned that the patient is not having splenomegaly. Sorry for that. In echinococcus granulosis from the liver, it can even result in, because it sometimes results in these cysts are so large where there is portal hypertension, and eventually the patient can have splenomegaly also. So till now, we're only familiar with one disease which does not have splenomegaly, and that is amoeba and amoeba histolytica. Other than that, uh, two diseases which have splenomegaly is schistosomiasis and the echinococcus granulosis also. Okay, what will be the sign symptoms? Nausea, vomiting, hepatosplenomegaly. The patient can have cough, chest pain, and hemoptysis also. Mostly it involves the liver. It can go to the lungs also, because and can result in the cough, hemoptysis, chest pain, as already mentioned. Diagnosis is you can get a clue from the eosinophilia. Diagnosis more importantly due to the ELISA serology, which can be helpful for the confirmation and for the follow-up also. Imaging is mostly done by the ultrasonography. That is the first line. How what you will see on the ultrasonography? A ring of calcification. What is this? This is filariasis, right? We talk about the Wucheria bancropty. This is lymphatic filariasis. This Wucheria bancropty, right? This Wucheria bancropty, eh, it is basically spread by the mosquitoes, or there are black flies which act as vectors and transfer these filaria, that is the Wucheria bancropty, here and there. And this Wucheria bancropty results in the obstruction of lymphatic vessels, and once it's obstructed, there is lymphedema, right? As you can see here, the simple thing which I want to mention is that it can even result in the hydrocele. Okay, it can result in the, as you can see this, it looks like an elephant shape, elephant legs, so it is called as elephantiasis. Okay, it can even result in the involvement of the breasts, even the genitals, and already mentioned it can result in the hydrocele and even the scrotal edema. What is the treatment? What is the treatment? Diagnosis, yeah, can be done by the serology, but what is the treatment? Treatment is diethyl carbamazine. Carbamazine. What is this? This is what we called as river blindness. And this river blindness, it is caused by loesis, right? Not the loesis, but it is caused by none other than your onchocerciasis. Onchocerciasis. This is caused by the onchocerciasis, right? Can you see it here? This river blindness is caused by the onchocerciasis, and as you can see here, it can result in the uveitis and even optic atrophy, right? And the treatment is again, what is the treatment? What should be the treatment which is used in such cases? Again, it is your ivermectin. Where do we use ivermectin? Plus minus doxycycline. What is the other usage of this ivermectin? This is a primary treatment for the scabies. What is the name of the mite which results in scabies? Sarcoptes scabi. What is the typical, classical or the classical manifestation or the presentation of scabies? The involvement of web itching. There will be web itching. Okay, and that means the web space in between our fingers. From the fingers, it will go towards the wrist, then to the trunk, okay, then towards the lower limb. This is what we called as, and from the lower limb it migrates again and goes towards the web space, and again the wrist trunk lower limb. This is what we call as cycle of Hibra. This is not asked in the exam, but yeah, you need to remember that sarcoptic scabies result in the scabies. Ivermectin can be used in scabies also. When do we use the primary treatment? The first line treatment is we go for the 5% or 10% permethrin. Okay, and we use it for like 1 or 2 weeks. If it fails, we again use permethrin. This is your question. And now if it fails, after second time if it fails, then you have to go for what? Ivermectin. Okay, done. Now onchocerciasis, onco. Okay, just if we just draw this O and just over here, I will just draw and fill. This looks like a cornea and the pupil eventually, and this is what we remember, that it results in the involvement of eye, uveitis plus optic atrophy plus river blindness. Now what is this? This one, this is loiasis, and this is what we called as Calabar swelling, and this is caused by, wait a second, can you copy it? This is caused by none other than loiasis. And what is the treatment for? Can you see it here? This is a 60-year male present with constant pain and itching in eye, and the patient is presenting with such kind of swelling. Even it can present, this such type of swelling can present in the wrist also. Okay, with the local or the skin itching. This is what we called as Calabar swelling. Can you see it here? This pile area, it is present over here, and this is what we called as loasis. And what is the treatment? Can you see it over here? What is the treatment? Diagnosis, of course, serology and all, but what is the treatment? Diethyl carbamazine. Diethyl carbamazine. Okay, done. This is how do you diagnose a case of loasis. Now, if we'll go back again uh, to help you to repeat to revise this. Whenever we talk about the traveler's diarrhea, we have a definition that means three or more stools, loose watery stools should be present over there, and plus in 24 hours, plus one of them should be over here. That means bloody stool, abdominal pain, fever, nausea, vomiting. Talk about the traveler's diarrhea, we talk about the bloody and the watery diarrhea. The patients have bloody diarrhea, and then the second thing should be the incubation period, which if it's 12 to 48 hours, think about the Salmonella E. coli. If it's 48 to 72 hours, think about Shigella and Campylobacter. If it's more than 77 days, think about the Entamoeba histolytica. What is the treatment for and amoeba histolytica? We have already done that. Then when we talk about the watery diarrhea, it is 1 to 6 hours. If it's 1 to 6 hours, think about the Staph aureus. Most importantly, there will be a history that the patient is, there's a history of that the patient has was in a party where he drank kind of milk or a cake or a carrot cake. Then it is a case of Staph aureus. If they talk about the eating of fried rice, it is a case of Bacillus cereus. And if it's 2 to 5 days, think about the cholera. If it is more than 7 days, think about the giardia. We have already mentioned about the giardia. Hiking, camping is a protozoa. Explosive watery diarrhea, flatulence, fatty stools, foul smelling, abdominal pain, non bloody diarrhea, flagella attached to intestine, malabsorption, KEDA. Papua New Guinea, very important. They are very, filled with giardia. Non-bloody diarrhea is present over there. Treatment symptomatic metronidazole, asymptomatic nothing. Pregnancy metronidazole or paramomycin. Yeah. When we talk about the anti-amoeba histolytica, results in the amoebiasis. Mostly the patients are asymptomatic. Even though the patients are asymptomatic, it can result in the ulceration, perforation, and the rest of the thing. Therefore, you have to treat the patients with the luminal agent, that is paramomycin. It can result in the bloody diarrhea, flash-shaped ulcer, liver abscess, and paste, appearance of the liver abscess, and the right upper quadrant pain. Right upper quadrant pain plus there will be hepatomegaly and all. How to diagnose stool microscopy, antigen testing PCR can be done for the diagnosis. If we went for the stool microscopy, you will see the erythrocytes present in the tropocytes. Why do we go for the antigen testing in the PCR? Because it helps us to distinguish between the anti-amoeba histolytica and the anti-amoeba dispar. And paste, as you can see over here, the patients having amoebiasis, liver abscess formation, amoebic liver abscess, patient will have fever, right upper quadrant pain, hepatomegaly, which will be tender. Serology and the imaging CT is done for the diagnosis in case of such liver abscess, that is the amoebic liver abscess. Extra intestinal manifestations already mentioned. More than 7 days bloody diarrhea, ulcer, and the flask shape already mentioned. Schistosomiasis, think about the vector as fresh snail, which then think about the circaria, which penetrates the skin, results in the involvement of local reaction, resulting in the swimmer's itch, right? And when we talk about the schistosomiasis, it has we have three types of schistosomiasis: Mansoni, Japonicum, Hematobium. Mansoni and Japonicum remains in the intestine, results in the intestine manifestation like abdominal pain, fever, myalgia, and urticaria. That is what we call as Katayama syndrome. If it results in the involvement of vesicle plexus, that is schistosomiasis, Hematobium. We have to think about the bladder carcinoma also. It results in the hepatomegaly and the fibrosis also, portal hypertension, in the granuloma formation in the pulmonary artery, that is the pulmonary and arteritis. Pulmonary hypertension is also there. Splenomegaly is also there. The patient can have the terminal hematuria. The local reaction which is caused by it is called as swimmer's itch, okay, or circariasis. And the patient can have, as you can see, ascites can be over there. Diagnosis, of course, by the X in the stool or the ultrasonography of that liver. If it is the Mansoni or Japonicum, then we talk about the treatment that praziquantel. If the patients have neurological signs symptoms, we can go for the glucocorticoids. Then when we talk about the hydrated disease that is caused by the Echinococcus granulosus present, these eggs are present in the dogs. They pass their stools which taken by the sheep, then go towards the humans when the sheep is eaten by the human. This Echinococcus granulosus remains in the intestine, then it can go to the liver, resulting in the hydrated cyst formation in the liver. Liver hydrated cyst, if it ruptures, even if it's a case of asymptomatic patient, we have to treat because it ruptures and can result in the anaphylaxis and the patient can die. Patient can have both hepatomegaly and splenomegaly, but in the MEBS, the patient was not having splenomegaly. In the lung, it can again result in the cyst formation. The patient can have cup dyspnea, hemoptysis, chest pain. The ring of calcification is present. Septate formation is present on the ultrasonography. Diagnosis is given by a clue that the patient is having eosinophilia. Serology is both diagnostic and used for the follow-up treatment. If the patient, if the ELISA is negative, can go for the cyst aspiration, but it's not asked in the exam because there's a risk of anaphylaxis. Imaging is done by ultrasonography, which is best initial CT, MRIs, and then the confirmatory after ultrasonography. Treatment is single. If the cyst is single and less than 5 centimeters, we can go for the albendazole. If the cyst is 5 to 10, we can go for the albendazole followed by peer. If this peer fails, we can go for the resection. Multiple and more than 10, we can go for the resection. If there is biliary obstruction, we can go for the biliary stent with or without the sphincteroplasty. Then we talked about the filariasis, where we first talked about the Elephantiasis that's caused by Wucheria bancrofti. It results in the obstruction of lymphatic vessels, resulting in the lymphedema, lower limb edema, elephantiasis, hydroceles, scrotal edema, and all. It can result in the lymph obstruction of breast. Even lymphatic filariasis is treated by the diethyl carbamazine. We talked about the river blindness, which is caused by the onchocerciasis. It can result in the involvement of eye, resulting in a uveitis and optic atrophy. The treatment is ivermectin plus minus doxycycline. The other usage of the ivermectin was scabies once it is if there is a failure of permethrin twice. Permethrin is a topical treatment. Remember that. There we went for the low acid, which results in the involvement of eye and results in the involvement of calabar swelling. This calabar swelling can present in the wrist also, and the treatment was diethyl carbamazine. That's it. Okay. So this was an overview of the first important points of uh, the infectious medicine. We have the second day of infectious medicine also. But before that, I just want you to watch that video which I have already recorded. Then we'll continue tomorrow from there on. We will talk about the malaria. That's important. We'll talk about the infectious mononucleosis. We'll talk about the Zika virus. We'll talk about the traveler's diarrhea, like how to diagnose them, which we have already mentioned. We'll talk about the infective endocarditis. That's it. Q fever. Yeah, Q fever is very important. Hepatitis A, B, D. I will just mention about some few points. That's it.